am Dr. Y. Premchandra PG Diploma Endocrinology student, University of South Wales, UK. Today I will be talking about FNAC thyroid. Every person suspected of thyroid disorders should be evaluated for presence of thyroid nodules by palpation, which can be felt if the thyroid nodule is more than 1 cm in size. Thyroid nodules can also be detected by ultrasound as an incidental finding. In this group of patients, FNAC are required if indicated. The complete history taking and physical examination directed to the thyroid gland and cervical lymph nodes should be done. Serum TSH and thyroid ultrasound are routinely done. History taking and physical examinations are directed to those having more incidence of malignancy, like family history of thyroid cancer, personal history of head and body irradiation, rapid growth of nodules, firm or hard nodule, hoarseness of voice or vocal signs of vocal paralysis, or fixation to the nodule to the surrounding tissue should be sought. A patient suspected of thyroid disorders should be evaluated for presence of thyroid nodules by palpation. Thyroid nodules are easily felt by palpation if the size is more than 1 cm. Or the thyroid nodules should be examined by ultrasound if the TSH level is high. In such group of patients, complete history taking and physical examination directed to the thyroid gland and cervical lymph nodes should be done. History taking and physical findings which may increase the chance of malignancy should be sought in this group of patients. Family history of cancer, personal history of head and neck or total body irradiation, rapid growth of the nodules, very firm or hard nodule, presence of hoarseness of voice or signs of vocal paralysis, or fixation of these nodules to the surrounding tissue. There are two methods of taking FNAC thyroid. One is palpation by FNAC, which is usually not done nowadays, and the second is ultrasound guided FNAC, which is more specific and yield accurate results. A patient with normal or elevated serum TSH should proceed to a thyroid ultrasound to determine if FNA needs to be performed. The indications for ultrasound guided FNA are a nodule of any size with suspicious sonographic feature like presence of hypoechoic nodule, nodule with irregular or blurred margin, presence of microcalcification, absence of halo around the nodule, intranodular vascularity, and nodules which are taller than wide. However, those nodules where TSH levels are depressed, this patient should have a radionuclide thyroid scan to see whether the nodules are hot or cold. If the nodule is hot, FNA is not indicated. A nodule that appears either iso or hypofunction on radionuclide scan should be considered for FNA based on ultrasound findings. Ultrasound guided FNAC of thyroid shows better result as the reported non-diagnostic rates is higher in the palpation FNAC. In a study by Gitrani in 2006, palpation FNA shows a 15% non-diagnostic rate, whereas in ultrasound FNA shows a 66.5% non-diagnostic rate. In 1998, Hatada et al. Have shown that palpation FNA have shown 30% non-diagnostic FNAC, whereas ultrasound FNA has 17% FNA. So ultrasound guided FNAC has a better result and accuracy. For this FNAC, we need to prepare the patient by clinical examination, physical examination, and evaluation of some blood parameters like prothrombin time to check if the patient have any bleeding disorders. Informed consent regarding the procedure of FNAC, the risks, and any possible complications should also be explained to the patient. Along with that, histories of the patient as told earlier about the irradiation, about the family history of thyroid cancer, any ultrasound examination, previous biopsy findings should also be brought by the patient. Requirements for this procedure are a good ultrasound, having a linear probe, antiseptic measures, then we need needles The needle need not be special echogenic, but a needle having 23 to 27 gauge, whereas 27 gauge is the optimal one is required. The needle is going to be attached to a 10 cc lever lock syringe. In some cases, without this locking syringe, we can also use the normal disposable syringe. We need betadine and alcohol spirit swabs, sterile dressing drapes. For the FNA procedure, after explaining to the patient and after confirming any other problems like checking the appointment time and any allergy to the drugs, any allergy to anesthetic Linocan, we prepare the patient and put the patient with the neck extended. The ultrasound is again repeated to confirm the presence of any nodule. Both the lobes of the thyroid are examined along with the isthmus. Presence of any cervical limb adenopathy is noted. After that, antiseptic precautions are taken. The neck area is painted with betadine followed by spirit, and sterile draping is done. There are two techniques of doing FNA by ultrasound. One is parallel and perpendicular, and it depends upon the operator. The biopsy that is to be taken needs to be adequate and representative. We require at least 3 to 6 separate needle passes in the nodule. More than 6 needle passes is unnecessary, as it may lead to trauma and blood may aspirate out with the tissue. After localizing the thyroid nodule on the ultrasound and after antiseptic precautions, the needle is inserted with the help of ultrasound probe. After 3 to 6 passes of needle is removed, and then the whole content of the syringe is aspirated into the glass slides and smears are prepared. There may be some side effects in this procedure, means pain at the site of puncture. In some cases, hematoma may occur due to injury in the small veins, so the patients are advised to apply pressure over the area for at least 20 to 30 minutes. In some cases, infections can occur if antiseptic precautions are not properly taken. Injury to trachea are rarely reported if the nodule is present near the isthmus. The patient is instructed to stay for around 30 minutes, and after checking that there is no hematoma, no bleeding in the site, the patient is asked to come back after 2 or 3 days for the biopsy report. The biopsy report could be of different types. It could be non-diagnostic, benign, or atopical follicular lescent, or it could be suspicious for malignancy, or it could be malignant. The FNAC report comes out to be non-diagnostic, like reports like blood only, absence of colloid, insufficient cellularity, and in such cases we need to follow up the patient by ultrasound, and FNAC may be repeated after 3 months. So, FNA thyroid, in conclusion, is highly accurate with high sensitivity and specificity. However, the accuracy in diagnosing thyroid abnormalities depends on the expertise of cytopathologists interpreting the biopsy specimen and the doctor performing the biopsy. Thank you.